Evaluating the role of community values on rights-based reproductive interventions in South Africa. South Africa's commitment to reproductive health is exemplified in its progressive constitution, abortion legislation, and ratification of international and regional human rights law. Despite the presence of these legal frameworks, little has been done to localize policy guidelines to reflect community contexts. More specifically, community norms and values are cited as one of the biggest barriers to accessing care on the local level. If policymakers continue to ignore the significance of these values in shaping access, pre-existing barriers to accessing care will only increase. I hypothesize that community beliefs create social and cultural norms, which play a significant role in shaping both demand for and supply of reproductive health services at the local level. I am particularly interested in distinguishing between the role of traditional leadership and religious leadership in influencing demand outcomes. Using a mixed methods, multivariate approach, I explore the effects of community values and socio-demographic indicators on individual demand. I primarily use quantitative multivariate regression analysis. However, previous qualitative field research conducted on barriers to accessing care is incorporated to contextualize the problem, as well as establish a precedent for this research. I merge all variables on the sub-regional level, with socio-demographic indicators merged on both the individual, respondent, and sub-regional level. Want of reproductive service is used as a proxy for measuring reproductive service demand. Want, the dependent variable of interest, is defined as need, method, and current use of family planning services for individuals. The primary metric used to determine community beliefs or our independent variables of interest in the study is trust. Trust in traditional, religious, and state leadership are all used as proxies for community values. This is done with the thought that by determining which institutions communities place significant trust in, policymakers can better identify which customs may facilitate interest in and access to reproductive care. Again, just for a visual display of how want is defined, we have folks that have no need but currently use, have an unmet need but no method, and have an unmet need and they currently have a method of family planning. Data is taken from the Afrobarometer belief survey data, USAID's demographic health and survey data, and then qualitative data from interviews and focus group discussions. Trust in traditional leadership is associated with an 11% increase in service demand on the municipal level, holding all other variables constant. Trust in religious leadership, however, is associated with a 14% decrease in reproductive service demand. And there's no significant relationship between trust in state leadership and reproductive service demand. This tells us that while traditional leadership may facilitate interest in seeking care, religious beliefs from community-based leaders as well as providers themselves may discourage seeking care. This is important to note when creating rights-based interventions on the local level. Race is another interactive variable of interest that I chose to explore. Among self-identified non-Black/African participants, trust in traditional leadership is associated with a 12% increase in reproductive service demand, while trust in religious leadership is associated with a 25% decrease in reproductive service demand. Further research should be done on why this might be. I use this model to further reinforce the importance of localizing intervention programming to reflect specific demographic and sociocultural environments. The differences between Black and non-Black participants suggest that intervention design should consider the role of race and potentially the specific historical contexts, such as apartheid, in policy design. Education is our final interactive variable of interest. Among primary educated folks, trust in traditional leadership is associated with the first 15% increase in service demand. Among individuals with the secondary education, trust in religious leadership is associated with a 17% decrease in service demand. And there is no significant effects for individuals with education higher than the secondary level. Previous research has thoroughly documented the role of education in reproductive service care in the country. The significantly stratified education system in the country, coupled with the varied findings, suggests that specific intervention should be designed to reach audiences with varied educational outcomes. I use this project to argue that community norms are operationalized through beliefs, attitudes, and practices. Understanding the role of this role that certain norms play in individual belief systems and community practice must be at the center of reproductive health service design.